Welcome to Cardiovascular Disorders in Children, Part 2, Congestive Heart Failure. When you review the pathophysiology of congestive heart failure in the adult population, you look down to what is the cause. First of all, they have some kind of a defect. Generally, it's hypertension, an MI, aortic stenosis, or coronary artery disease. And that leads through the cascade of them retaining fluid because the heart isn't effective as a pump, and then we get left or right heart failure. Now, when we compare that to children, the cause is very different, but the ultimate result is the same. With children, in general, we start with some type of a congenital heart anomaly, and the volume change and or cyanosis is present because of this. There can also be a cardiomyopathy from excessive contraction, and therefore the muscle is going to enlarge. So now we go through the very same things that the adults do. The heart is less effective in its ability to pump the blood. As a result, the kidneys do not get the adequate flow that they're used to, so they start holding on to sodium and water, and the circulation volume actually increases. Over time, the heart increases in size, and it becomes less and less effective because it can only stretch its muscle walls so far. As a result, the ejection fraction is reduced, the preload and the afterload is increased, and then we start having left failure symptoms of pulmonary congestion, increased work of breathing, the retractions, the nasal flaring, color changes, and as it backs up even further, now our right heart is affected. And so we see the signs of systemic congestion in the form of edema, the S3 heart sound, and we have an enlarged liver because it's so congested with blood. And now we're going to see the heaving of the precordium. So what are we going to do? What is your plan? Well, you can anticipate that you're going to be administering medications to this child. We administer diuretics to decrease the circulating volume. Same thing we do with adults. So we're going to give the furosemide or chlorothiazide and monitor your potassium levels, and you'll be giving those supplements as needed. We can also administer ACE inhibitors to decrease the vasoconstriction. It also decreases the retention of sodium, therefore decreases the retention of water, and it decreases the afterload. But always remember, you must remember to check the K plus level because ACE inhibitors cause retention of potassium, so make sure you're looking at your electrolyte panels. We also administer digoxin, and this will improve the contractility of the musculature. The end result is improved cardiac output and a reduction in the heart rate. We like to do an EKG prior to the start, and these kids will be on a cardiac monitor anyway. Remember that when we begin DIG, we have to digitalize them, as in we give them a loading dose, and that is based on the weight and the age of the child. Once they are at the desired level, they get switched to the maintenance dose. So you have to monitor their DIG levels, and the desired level is between 0.5 and 2 nanograms per milliliter. You need to know that. When do you draw the DIG? 6 to 8 hours after the previous dose, and then report the results to the physician. After we get this kid on the maintenance dose, we're going to repeat the level every 7 to 14 days until cardiology is happy with the results, and then they can stop. Monitor the K plus levels again, and make sure that this kid is producing urine. Toxicity of digoxin in a baby can be a bradycardia, and in children, a tachyarrhythmia. They also have nausea, vomiting, and they no longer want to eat. It is very important that you take the apical pulse for 1 full minute before you administer digoxin. If the heart rate is less than 70 to 85 in a child, and the cardiologist will tell you, are they 70 or are they 85? Or if it's less than 90 to 100 in an infant, you hold the dose and you notify the physician. Another important nursing intervention is weighing the baby, and we want to try and weigh them on the same scale at the same time every day. You must notify the physician if an infant gains more than 50 grams in a 24-hour period or if a child gains more than 200 grams in a 24-hour period. Additional nursing interventions include chunking your activities together so that you're not constantly bothering this child. Let them rest. They have very little energy reserve, and don't continually make them do things. They will be on strict I&O hourly. Increase the head of the bed between 30 to 45 degrees to improve their breathing. When we feed these babies who are on bottles, we want to use a soft nipple that has a large bore so they do not have to suck so vigorously to get the fluid to come out. After 30 minutes, if this kid cannot get all the food down, you're done. You're going to put in a NG or an orogastric tube, and you're going to gavage feed them the rest of the feeding. Also, keep them propped upright when you're feeding, and give them their feeding before you do anything else. They have the most energy when we're first waking them up to feed, or they're waking up and they're telling you they're hungry. Feed them immediately so that we can get them to get the food in as much as they can on their own. We give them high-calorie formula. Typical formula is 19 to 20 calories per ounce. We can give them 24, 27, 30, whatever it is based on their failure to thrive status. We're going to give that. For the older kids, we're going to give them the calorie-rich foods. More calories in a smaller portion size so we get the more bang for the buck kind of a theory. We want to limit the oxygen that we give them. Just because they have a cyanotic heart disease doesn't mean that the oxygen is actually going to do anything, because it's the defect that's causing it. It's not their lungs. Parent education is very important with congestive heart failure. You need to teach them about digoxin. They also need to check this child's pulse for a full minute, and you need to give them the parameters of when to hold the dose. They should give their digoxin an hour before or 2 hours after a feeding, and they are not to put the digoxin in food or a bottle. If they don't finish what it is the parents are giving them, the child isn't getting a full dose. You need to talk to them also the same signs and symptoms you're watching for dig toxicity. They need to know, and tell them exactly what the dosage is and any labs that might have been ordered. In addition, we want to teach them about the signs and symptoms of a worsening heart failure. So excessive sweating, increased work of breathing, the same things you're looking for when you're feeding a kid or when you're taking care of them. If they're not urinating the way they usually do, are they more fatigued than usual, not taking in their food and fluids the way they're supposed to? And do they notice that the child has either lost weight or is gaining weight? And then last but not least, teach them CPR. And this ends congestive heart failure.